After the segments with the skeletons and the Prezi presentation, just the regular old PowerPoint seems kind of dull. But that's okay. We'll get over that. So after talking about the innervation and the muscles and the osteology and the kinematics for the hip, and now we get to the point where we say, well, so what? Like, why do we care about all this stuff? Functional considerations. How does the hip function? What does it do? What do we do when it doesn't function right? All sorts of good, interesting stuff. So in the text, this information is all sort of in between all the different muscle descriptions. But I like to have the muscles, describing it with the rubber bands on the skeleton, and then have the functional considerations a little bit separately. It is good to interleave the information and sort of get it all together in your mind. So in the book, there are a lot of the little clinical insight boxes, which are really fascinating to read when you think about the implications on the human body. So the learning objectives for this section, I want you to be able to identify the force couples that perform anterior and posterior pelvic tilt. So force couples, of course, are two muscles pulling in opposite linear directions, producing the same rotary direction or producing torque in the same rotary direction. So we have groups of muscles that do anterior pelvic tilt and posterior pelvic tilt. I want you to briefly explain why we would instruct a patient to use a cane of the opposite of their affected hip. So that comes up in the clinic every single day. I swear I talk to somebody about it every single day, or, at least every other day. So I want you to be able to describe how an adductor may act as a flexor or an extensor. And it's all about line of pull. Remember, any muscle, anytime that we're talking about any muscle action, line of pull is the key thing you want to look at. And how does the line of pull change to make something a flexor versus an extensor? I want you to be able to describe positions of active and passive insufficiency for the major multi-joint muscles crossing the hip. So of course, we're mostly talking about the rectus femoris and the hamstrings. Those are our major multi-joint muscles crossing the hip. And we could say iliopsoas as well, but we're talking rectus femoris and hamstrings for the most part. When we talk about the trunk muscles towards the end of the quarter, we'll probably bring the iliopsoas back for a guest appearance, just to talk about passive and active insufficiency again at that point. I want you to be able to describe Trendelenburg gait and Trendelenburg sign and identify the muscles involved, and describe the actions of the hip adductors during stance and gait. This is super, super functionally important in the clinic. So I like to say all muscles are important, but some are more important than others. Hip abductors are right up there. We're always working on hip abductors in the clinic, and knee extensors are the other ones. So quadriceps and glutes. So the force couple that performs the anterior tilt of the pelvis, you actively anterior tilting the pelvis is created by using hip flexor muscles to pull the anterior pelvis towards the anterior femur, and trunk extensor muscles, so the erector spinae muscles, to pull the lumbar spine basically into extension. So the erector spinae muscles also attach on the pelvis, and so basically they're pulling the posterior side of the pelvis up, while the iliopsoas and other hip flexor muscles are pulling the anterior side down, producing that anterior pelvic tilt. So in the book, it describes it as a push, like push-pull when turning the steering wheel. One hand is pulling down and the other hand is pushing up. But most of us have power steering, and so we're not horking the steering wheel around. Anyway, if you've ever driven a car without power steering, you know what that's like. So the erector spinae muscles are pulling upward on the posterior pelvis. At the same time, the hip flexors are pulling downward on the anterior pelvis to produce that rotary motion, to produce the torque that is going to perform the anterior pelvic tilt. Okay, so the opposing muscle groups, the antagonist muscles, have to have enough stretch in order to perform that too. So the antagonist muscles to the hip flexors are the hip extensors. So the hip extensors are being stretched passively, and while the hip flexors are contracting, and the trunk flexors are being stretched while the trunk extensors are contracting. So there has to be that play between the other muscles, but the force couple is between the hip flexors and the trunk extensors for anterior tilt. For posterior tilt, it's the trunk flexors and the hip extensors. So it's the opposite. The trunk flexors are pulling up on the anterior pelvis, and the hip extensors are pulling down on the posterior pelvis. Posterior pelvic tilt reduces lordosis in the lumbar spine. Anterior pelvic tilt increases lordosis in the lumbar spine. So exercises involving the posterior pelvic tilt are often used clinically to address the low back problems that respond well to flexion. So spondylolisthesis, stenosis, spondylosis, so the S's. And when we're talking about disc, we often work on anterior pelvic tilt because we're trying to get lumbar extension and get pressure off the discs. So we'll talk more about that in the spine chapter, but just know the force couples that are working on posterior pelvic tilt: trunk flexors, hip extensors. For anterior pelvic tilt, trunk extensors, hip flexors. So one way or the other way. Okay, hopefully that makes sense. So the abdominal muscles, in the way that they act in a posterior pelvic tilt, they can act as proximal stabilizers for the hip flexors. So hip flexor muscles are used for lots of different activities that are dependent on stabilization provided by abdominal muscles. A big one that you think about is a straight leg raise, or just lifting your legs up to get them off the bed or something like that. And if, like, right now in your life, it might seem like that's an easy thing to do that you don't have to think about, but a lot of our patients that we're working with, they have to think about it every time, and it's really challenging for them. So for various reasons. So if you have weakened abdominal muscles that can't stabilize your trunk, if you attempt to flex an extended leg, a lot of times the trunk flexors can't keep your spine flat, and it results in an unwanted anterior pelvic tilt and excessive lumbar lordosis, and incidentally can put a little strain on the back if you have stenosis or spondylolisthesis, anything like that. So by stabilizing with the trunk flexors, it allows you to get a better leg lift. So that can be really relevant for people being able to do their activities of daily living without exacerbating their back pain. So super important to have strong abdominal muscles as stabilizers for hip flexion. So I said earlier that the hip abductors are one of like the most important groups that we work on in physical therapy. Hip abductor muscles play a critical role in controlling the pelvis in the frontal plane while walking. So when we're walking, we're translating. We have sagittal plane movement with hip flexion and hip extension. We also have frontal plane movement with the pelvis moving from side to side, and there's transverse plane movement with a little bit of trunk rotation. So the gluteus medius and gluteus minimus, and to some extent the TFL, help control the pelvis while you're walking. During the stance phase of gait And I know we haven't talked about gait yet, and we won't in this class. You'll have it in another class, but we'll kind of talk a little bit about it. So when you're in the stance phase on one leg, you're in the swing phase on the other leg. So the leg that you're standing on, the hip abductors have to hold the pelvis level. If the hip abductors are weak, the hip that you're standing on will go out to the side and reduce your stability. And that's what Trendelenburg gait is, and we'll talk about that in a second. So as the hip abductor muscles stabilize the pelvis, they also create significant forces against the hip. So if you have someone with a painful or unstable hip joint, this could be a problem. So a lot of times when you see someone in the clinic and they are having trouble stabilizing during the stance phase of gait, it could be weak abductor muscles, it could be damaged abductor muscles, it could be damaged innervation to the abductor muscles. So we're talking about the superior gluteal nerve, which comes from L5, S1, S2 level. So there could be lots of different things going on that are causing that. So if somebody has a painful joint and we're trying to reduce the pressures that are crossing that painful or weak hip, one way to do it is to use a cane in the hand opposite the affected hip. So the cane is used to reduce force production requirements of the hip abductors, reducing compressive forces through the joint. By using the cane in the opposite hand, it allows the pelvis to be held level. So the cane actually provides a downward force on the opposite side, lifting the affected side. So it decreases the compressive forces on the hip. So a lot of times we are having to do a lot of education on the use of assistive devices. If you just hand someone a cane, most of the time they will use it wrong. They'll do what I call Hollywood cane walking. So it's like the guy on House or Mr. Bates on Downton Abbey, where they hold the cane up against their hip and they kind of lean on it. That is not the correct way to walk with a cane. Not only is it not helping your balance any, it's also not unloading the affected hip. So if Mr. Bates would just switch his cane over to the other hand, his gait would be a lot better and we wouldn't have to feel so sorry for him. He is sort of a sympathetic character. Anyway, the whole idea of using cane in the opposite hand is to reduce the compressive forces on the opposite hip abductors to stabilize the hips. So we'll try it in the lab with some canes and see how it feels. So let's come back to this one and we'll talk about Trendelenburg gait and reversal of muscle function. So when I was talking about origin and insertion in the muscle chapter, I said normally the insertion moves towards the origin when the muscle contracts, when it's a concentric contraction. Reversal of muscle function is usually closed chain and the origin moves towards the insertion. So when you stand on one leg, the distal segment of the femur becomes more stable than the proximal segment. So the origin moves towards the insertion. So in closed chain, the distal segment is more stable. So without the abductors contracting, the pelvis would drop to the opposite side. And so the weakness of those abductors is called Trendelenburg gait. So if you have weak hip abductors on the right, standing on the right, the left side drops. So, and I think of it not even as much as the left side dropping, but as the right side going out to the right, going laterally to the right. So there is a video in the module that shows someone with Trendelenburg gait. And once you've seen it and you figure it out, you'll always be able to identify it. It's very easy to identify. So it's a result of weakness in the hip abductors. So the reversal of muscle function, in this picture, it's his left side that's weak. The left hip abductors are supposed to contract to keep the pelvis steady when you're in the stance phase on the right and you're lifting your left. When the left hip abductors are weak, the right side of the pelvis drops and the left hip goes laterally to the left. Okay, hopefully you can see that in the first picture. So sometimes if someone's hip is going out laterally to the left, they will move their trunk over to the left side to sort of compensate for that, and that's called a compensated Trendelenburg. And uncompensated is the hip just goes out to the side, and that is a result of weak hip abductors. So mostly we're talking about gluteus medius and gluteus minimus. Okay, so I'm going to go back up to the hip extension. So one of the reasons why you get groin pulls or adductor pulls with running or jumping, or particularly sprinting, is there high-powered activities that require a lot of hip extension torque. Because when you're trying to run fast, every power stroke with your foot is hip extensors pushing back on your femur. So the position of hip flexion elongates hip extensors, better enabling them to produce large forces. So you see sprinters on the track starting in that hip flexion position in the blocks, so they can just jet off when the gun goes off. So a lot of hip adductor muscles are converted to extensors when the hip is in the flex position. And the way that happens is, in order to be an extensor, it has to be posterior to the medial lateral axis, right? So if you're in hip flexion, the adductors have a line of pull for extension, or they have a better line of pull for extension. So the example they give in the book, they say it's like switching gears in a car. The position of hip flexion strongly engages available extension torque of numerous hip muscles. So the adductor magnus is huge, and it has an extensor head, which is the posterior head, and it has an adductor head, which is the anteromedial head. And the extensor head of the hip adductor just has a better line of pull if you start out in hip flexion. So we're sort of increasing the length tension relationship on that and getting a better line of pull for extension. So we can, by changing the position of the hip, you can change the line of pull of the adductors. So hopefully that makes sense, and we can talk about it more if it doesn't. So this is more about the same thing though. So regardless of hip position, the extensor head of the adductor magnus is an extensor. So it's posterior, it's in a more, it has a line of pull for extension. The remaining hip adductors can function as flexors or extensors depending on hip position. And they can provide flexion torque or extension torque depending on what your hip position is. So switching from flexion to extension during running and jumping may explain the adductor susceptibility to injuries when running. So that's why a groin pull is a really common injury with running. So the adductor magnus always has an extensor head, but the other ones can become extensors if you move them into a line of pull for extension, because they're in that medial part, and moving the hip, you can give them a different line of pull. So it's pretty interesting. We have these versatile muscles that we can use for what we need them for. Kind of neat, I think. So Trendelenburg gait. So really, like all joints of the body, the hip has to be stable and mobile. And we expect a high level of stability and maybe not as much mobility, but still a lot. So if we compare the two ball and socket joints, the shoulder joint and the hip joint, we expect an incredible amount of mobility from our shoulder joint and not as much stability. In the hip, we expect an incredible amount of stability and not as much mobility as the shoulder, but still a lot of mobility. The ball and structure socket of the joint not only provides a lot of mobility in all three planes, but it's also really stable because of the deep acetabulum and really strong ligaments. So those the ischiofemoral, iliofemoral, and pubofemoral ligaments are beefy, strong ligaments, and they provide a ton of stability. So in the shoulder, the socket's not quite as deep, so it's not quite as stable, but it's way more mobile because we can't do with our hip what we do with our shoulder. Because of the hip's central location, dysfunction of the hip can generate a number of problems up and down the kinematic chain. So I always say, like, oh, the hip goes, there goes the neighborhood, right? It can cause problems with low back and knee and foot and ankle. So very important to the function of our body. So really, in treating lower back dysfunction and lower limb dysfunction, so whether it's knee or ankle or hip, we often have to treat the hip as well, because facilitating proper alignment and function of the hip helps those other areas get better as well. So hip exercises are integral to a lot of therapy programs. If you're working on balance, you're working on hip abductor strength. If you're working on lumbar stability, you're working on hip strength. If you're working on knee issues, you're working on hip strength. So hips are hugely important in any sort of rehab program. And that's one of the reasons why we start talking about them first, even though it's chapter 9 in the book.